So welcome everyone. Thank you for joining us for today's webinar. If you have experiencing knee pain, you should know that you are not alone. Many people experience this issue and we are here to provide a solution for it. If you are dealing with knee pain, there are a variety of options that can help you to manage your symptoms and get back to doing the activities you enjoy. Don't let your condition stop you from living your life. Today we are going to talk about new technology for treating knee osteoarthritis. Such an important topic as you all need to know. It can be hard to figure out the best way to care for your knee pain. This session will help you to manage your knee pain and help them to live a pain-free life. As we invite our expert orthopedic surgeon, Dr. Mahmoud A Hafez, to the webinar, I would like to tell you today's show is going to be very interesting and you can ask all your questions and queries about knee pain treatment and doctor will answer all your questions to you. Do stay with us till the end of the show. So before dive into the show or before I invite our guest for the day, let me thank all of you on behalf of Anavara. Anavara is medical wellness and health facilitator. We provide medical tourism across the globe, providing you with a list of hospitals and experienced doctors and also keeping it in your budget. Let's invite our today's specialist. Our expert today is an expert orthopedic surgeon, Dr. Mahmoud A Hafez. He has 7 professions: orthopedic surgeon, teacher, surgical trainer, researcher, editor, manager, and a poet. He has been interested in orthopedics since his graduation and worked in 5 countries: Egypt, Saudi Arabia, UK, US, and Canada, with different healthcare systems. Each country has its own endemic diseases and challenging conditions. His special interest is hip and knee orthoplasty. He trained and worked in UK for more than 10 years, passing through basic and higher surgical training, orthoplasty fellowship, and locum consultant. He currently works as professor and head of orthopedic unit at October 6 University in Cairo, Egypt. It's a privilege and honor to introduce Dr. Mahmoud A Hafez. Welcome you, doctor. It's been a very, very happy Saturday and a special Saturday. Having you here on the special occasion makes it even more special, doctor. So without further delay, let's get started. I'm handing over the session to Dr.
Thank you so much, and thanks to Anavara team for inviting me. And I hope you enjoy this session, and we'll try to make it as interactive as possible. I am happy to take questions in the middle, but it would be better if we keep it at the end, at the question and answers session. Now, just a bit about my training. I was trained in UK for more than 10 years, but I worked for about 20 years or so. And I work in the US and Canada. And now I'm settled in Egypt and I go to UK about 3 months a year. My interest is knee osteoarthritis and joint replacement in general, whether hip or knee joint replacement. When we talk about, this is knee osteoarthritis. What is the meaning of osteoarthritis? It is a slowly progressive degenerative disease. And what this means, it is first is slowly means it takes time and it is a chronic disease. It is degenerative, which means it is like a wear and tear. So it is associated with aging, and it is progressive. So once osteoarthritis started, it will unfortunately progress. As you can see here from the picture, this is a normal joint where you see the bone covered by cartilage, and this cartilage is really very smooth and has no roughness at all. And this is the normal. You can live for about 100 years of age without having osteoarthritis. So aging does not always mean that you will have osteoarthritis, but it is associated with it. Okay, and once the arthritis starts by causes which we will see later on, you will see this smoothness of the cartilage is gone and it become really rough. And then once the cartilage is gone, the underlying bone become weak because the bone is really covered by the cartilage, which is very protective, that prevents the cartilage from being worn if the friction is between bone and bone. As you see here from the text, that it usually affects middle-aged and elderly people, and it leads to the gradual wear and loss of articular cartilage and then bone. You can see it obvious in the hands when the hands has got osteoarthritis, and you can see the swelling and the deformity and the stiffness. Here is again another picture of the knee joint showing the cruciate ligaments, showing the menisci, medial and lateral meniscus, and also showing the articular cartilage, which is that white cover on the bone, and it is damaged. And then the bone become exposed, and then the condition will progress. When we do X-ray for the knee, which is more important for me and for many orthopedic surgeons who has experience in osteoarthritis, is to have a weight-bearing X-ray, and this is more important even than MRI. As you can see here, this X-ray on the left side, it is done in a supine position, means the patient is lying down. And the one on the right side here is the patient weight bearing. This is just only a few minutes after taking the other X-ray. There is a huge difference. We need always a weight bearing X-ray, a standing X-ray, because it shows the body weight. When the body weight is there, you can see that the space here, which is supposed to be filled by cartilage, is completely gone, and the bone is touching the bone. And this is not the case here when the X-ray was done in the position lying down. Okay, so what we normally see in X-ray, we see the bone, and then we see that joint. The joint here, that black shadow here, is actually the cartilage. It does not show in X-ray, so it shows like this. And when the cartilage is worn out, you can see it. See, you see the space here on the lateral half of the knee is filled with cartilage, but on the medial aspect here is almost gone, and it is completely gone here when you do a standing X-ray. So it's important to do a standing X-ray. So what are the causes of osteoarthritis? There are several causes, but I'm listing here the most three important causes, which is osteoarthritis, which we're going to talk about, and rheumatoid arthritis, which is a rheumatological disease, okay, and post-traumatic. Post-traumatic means patients who had accidents in the knee injuries like footballers or other knee injuries that can lead to arthritis later on. So osteoarthritis is the most common joint disease in general, and the knee is more likely to be damaged by arthritis than any other joint. And the osteoarthritis of the knee is even more prevalent in Far and Middle East due to traditional and religious habits. So what are the symptoms? You usually have pain from the arthritis with stiffness, and stiffness means that you cannot move the joint in the normal range of motion, and then you get swelling. Patients with mild symptoms can manage their arthritis without treatment or with non-surgical measures. However, severe symptoms can limit the walking distance and disturb sleep and interfere with other activities of daily living. 40% of patients with knee osteoarthritis rate their health as poor or fair, and they report a higher degree of emotional stress. So as you can see here from the symptoms, that there are a huge impact of knee osteoarthritis on patients. And this impact is not just only on health and emotion, but it also has good financial or economic impact and also social impact. So what are the treatment for knee osteoarthritis? The treatment, there are several methods which we call them non-operative treatment or non-surgical treatment. And then at the end is a surgery. So we don't normally resort to surgery before we exhaust all other measures. However, if somebody comes with a severe knee arthritis, then surgery is the first line of treatment, because that is this is the standard treatment when the knee arthritis became severe or advanced. We classify the degree of arthritis into mild, moderate, severe, and advanced. Okay, so for a mild and moderate, then you can use all these non-surgical measures, which start with the weight control. We have to reduce the body weight because there is some association between obesity and osteoarthritis. And also you should do proper exercises to keep your knee moving, and also to strengthen the muscles, because these muscles is going to decrease the load on the knees. You can use heat and cold therapy with hot packs and cold packs, and also pain medication, which is mostly painkiller and analgesia, And there are other pain relief options, which I'm not going to talk about a lot um, uh, 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 um, here, but we can just touch on them. You know, like a steroid injection is commonly used, but you cannot use steroids in patients who are diabetic, and steroids also, they have many side effects. So recently, and I want to say recently, it is in the last uh, 20 years or more, there has been other injections that being given inside the knee, like hyaluronic acid or hyaluronate, and these are material which is already present in the cartilage normally in the body, and when you give it, it has no side effects. And this injection is commonly used for knee osteoarthritis. The other injections called plasma, and the plasma or the PRP is also as an alternative. The PRP, you have to take a sample from the patient blood sample, and then from this blood sample, you can process it with a centrifuge, with a specific machines where it separates the cells and make a rich plasma, where this can be re-injected inside the knee joint. There are other modalities that came also recently, but remember that all these modalities are not um, radical treatment. They are just only can control the pain, but they are not radical treatment. Um, So one of these modalities that came recently, where they take a sample from the cartilage in the ear, and then they process it and they inject it also inside the knee, and all these things are not still experimental with this. Also, other treatments like stem cell and other things, these are still experimental and not proven, and also not radical treatment. None of these can cure severe osteoarthritis. None of them can cure severe osteoarthritis. Okay, but they are only described for mild and moderate, and they can only alleviate the pain and symptoms, but usually they don't change the course or the uh, what we call it, the natural history of the knee osteoarthritis. So they don't affect that. They cannot they cannot replace the cartilage. The cartilage, once it's gone, cannot be replaced. And this is a very important information from basic sciences that we know. Okay, other measures that could be used is a changing lifestyle and stress control. So if there are certain positions that can hurt the joints, we will try to avoid them. You know, like squatting and kneeling down. These positions, when you have osteoarthritis, then you have to limit, you know, the lifestyle. Okay. Um, Many of the questions come to me about, you know, like religious and prayer. These are only for few minutes, and this does not is a good exercise for the knee, and does not give osteoarthritis as such, but it is, if it is a habit, um, and it became a tradition, sitting down on the floor, cross legs, and squatting and kneeling down, then osteoarthritis, yes, it will happen. Um, the last thing is surgery, and that's the mainstay for my talk here today, which is we're going to talk about total knee replacement, and abbreviation is TKR, and also called the total knee arthroplasty, which is a seam. Okay, this is currently one of the most surgical procedures that is done in orthopedics. It's a treatment of choice for advanced knee osteoarthritis and for patients aged over 55. Still, we can do it for patients who are younger than that if there is a need. I did joint replacement for patients who are less than 20 years of age, and 20s and 30s, due to the need for this. The majority of patients who after the surgery will recover, and they experience dramatic relief of pain, and will be able to perform activities of daily living after recovery from surgery, which takes only a few weeks. Other symptoms usually disappear, and the patient can regain their normal independence, and they can walk a lot. We advise patients in UK that they can walk up to 10 miles a day, which is about 16 kilometers. And the survival of knee replacement, as you can see here, is 15 years in 95% of patients. Even now, there are good centers of excellence who reported survival of more than 20 years in 95% of patients. And this means that the patient can enjoy walking that distance for several kilometers over 15 or 20 years or more. There are problems. I mean, this is not magic. It is not something that is a panacea where you don't have anything as a drawbacks. No, there are drawbacks. There are some problems that could happen, as you can see here, DVT, which is deep venous thrombosis, pulmonary embolism, the clot can go through the lung, chest infection, urinary tract infection, wound infection, dislocation. All these things could happen, but most of these things are temporary and could be cured. Occasionally, that PE can cause fatal problems, but this is the incidence of that is very low, and also we give medications to prevent this happening. There are major problems like loosening or infection, and loosening means that the joint replacement itself become loose from the bone. And mortality, as you can see here, is extremely rare. So what is the aim of that total knee replacement? First is that we need a technical success. So we need to do the operation very accurately in order to get a long-term success. And also we need performance. We need good performance and survival of the implant. We need optimal recovery. So the short term, we should not make the patient suffer immediately after surgery. So we should reduce the pain and control the pain as much as we can and improve the function. And this is crucial. And also we need to reduce the complication rate, and we need to make the surgery cost effective. In order to achieve all these aims, is really extremely difficult, because if you know how we do knee replacement, then you will realize it is impossible to achieve all these aims at the same time. Okay, this is how we do knee replacement. We open the knee from the front here, okay, and here is the damaged cartilage and bone, and we need to fit these prosthesis inside the knee. So in order to fit that implant here into the femur, the distal part of the femur and proximal part of the tibia, we need to shape the bone in order to fit the internal geometry of this prosthesis, okay? And therefore, we have to make cuts in the bone here, and these cuts has to be done or have to be done absolutely accurately, because any deviation which is more than like 3 degrees can affect the survival of the implant. So in order to do these accurate cuts and get this implant or the prosthesis fitted exactly as if it is a normal knee joint, in this case, we have to do a lot to make sure that this is done perfectly well. And therefore, there are a lot of instrumentation that we use during surgery in order to achieve this. As you can see here, this instrumentation here, a lot, they are more than 300. They are complex, they are invasive. We have to go inside the medullary canal and we have to make sure that all these problems with the instrumentation system being replaced or have an alternative. Unfortunately, this instrumentation system is still in use, and this looks like the standard for doing a knee replacement. And that's why we're talking today about new technology, how we can replace all these conventional instruments that it is done by most of the surgeons worldwide. One of the problems with these instruments is that over time, since the late 1970s, since it was introduced, are still the same. They modified it several times, but they are making it even more complex. And they have a lot of all these problems are still the same. They are very expensive. You can imagine that there are many countries in Africa, they don't have these instruments. They don't have the privilege of having a knee replacement because this instrumentation are quite expensive, and the cost is around $100,000. So most of the hospitals, they don't stock these instruments. These instruments come with companies or distributors who have the prosthesis or the implant. So they come like on loan. and therefore their cost will offset towards the cost of the prosthesis, and that make the knee replacement very expensive. So when we look at the advances in arthroplasty in order to get rid of these instruments and also improve the prosthesis, there has been a lot of improvement in implant materials. Metal, that is something related to hip replacement, and this became obsolete now, is not good, and it's the same for ceramic and ceramic. For the knee replacement prosthesis is still the same. There has no been any advances on the implant material as opposed to the hip replacement. And in my title here, I'm talking about advances in arthroplasty in general. So for the hip, yes, but for the knee, the same prosthesis that has been used for the last 40 or 50 years is the same with very slight modifications. So they thought about a new procedures, hip resurfacing, and this didn't work very well, and that's for the hip. For the knee, there is a unicompartmental, which is a half joint replacement of the knee. We're going to talk about this. And minimally invasive, where they make small cut. But that three above advances did not really work very well for knees, apart from the last one, which is a computer-assisted surgery. And this is the thing that we're going to talk about. So basically, the technology that we're going to talk about is computer-assisted surgery. Here is just to show you what is meant by a half knee replacement. Half a knee replacement is just when you replace half of the knee. So if you look at the x-ray here, you see that the cartilage on the lateral side or the outside half of the knee is good, but on the inside is bone and bone. And here you can use a half joint replacement, where you can replace only that half which is damaged and leave the other healthy half as it is. Here is one of my patients who had this bilateral unicompartmental knee replacement, which is a half knee joint replacement. And the recovery is usually quicker than the total knee replacement. This patient, just only 2 hours after surgery, if you can see how much is bending their knees. The bandage is quite long, but actually the scar is quite small, is the size of a finger. And these patients can go home same day or maybe the next day, and they can have the two knees done together. So it's a good operation. When we talk about minimally invasive, which means that we can make a small cut rather than a big cut, I apply this for the hips more than for the knees. So if you look at the red line here, this is the traditional scar for a hip replacement. What I do this minimally invasive surgery, where I do my hip replacement from a small scar. But for the knee, I use the new technology, which I'm going to show you later on, which is really minimally invasive. It is a type of computer-assisted surgery. And here, when we look at computer-assisted surgery, there are three things. They are robotics, they are navigation, and they are patient-specific instrument, which is the mainstay also for my talk today. Robotics, we're going to show some examples. Here is just a navigation, which is just exactly like the GPS that you use in your phone when you are heading towards any place and you put the GPS to guide you. That's exactly the same. So we have like a GPS inside the operating room to tell us what to do, and that's called navigation. Navigation is quite expensive tool, and it's more than $100,000, and not many hospitals they have the navigation. So when we talk about the KAIS, or a computer-assisted orthopedic surgery, this is a definition which I was published in one of the textbook, which is the use computer-enabled technology in order to help surgeons to plan and to perform the surgery well. And this includes so many things. And as I mentioned, the main three tools are robotics, and navigation, and then patient-specific. This is a classification which I was published before. Okay, and the computer-assisted surgery is actually now is everywhere. Is not only in orthopedics. It is. There are so many specialties in surgery where they have a robot that can do the surgery, and we have artificial intelligence tools that can help in making the surgery. And this made a revolution. So if you look at the medicine in general, you see in the past we were using something like stethoscope like this, and then in the current decade here we're using many of the wearables so that you can have Apple Watch or Samsung Watch that has got many of the health parameters or measurements that can do for you. And this is the next decade where robotics and artificial intelligence is going to be in medicine. Here is a touch about robots, how to use robots in knee replacement. So, for example, here is a robot, and this robot looks like industrial robot. It's quite a big machine that goes inside the operating room, and it's covered with something that is sterile so that it can not introduce any infection inside the patient. Okay, and you can see the operation be done with the robot. Here is another way of robot, which is a handheld robot. So it is a robot which is small. It's not like a big industrial robot. You can hold this in your hand and then you can perform the surgery. And here is a camera and also the screen where you can see everything. I actually was working in Pittsburgh in US when this handheld robot was just a prototype, as you can see here on the left side. And now this is becoming very popular, and there are many hospitals, especially in the Gulf area here in Middle East, they have this robot, and definitely in Europe, States, and many other places, they have this robot. Here is, as I mentioned, that the robotic technology had been used in many specialties. Here is a conference that was done in London, and I was participating, representing the Orthopaedic robotic experience. And all other speakers from many different specialties like urology, cardiosurgery, neurosurgery, general surgery, gynecology, ENT, all other specialties. Now they've been using robot. This is the navigation, which is the GPS that I showed before, and this is how it works. So rather than a global positioning system or a satellite in the sky, here you have a camera inside the operating room. So this looks like the satellite, okay? And this will track the pins that's inserted in the bone here, and it can send infrared diodes in order to guide the surgeon and tell the surgeon that he did the proper step or the cuts in the knee properly. Here is a virtual reality, and this is another thing which is beyond the scope of our talk, but just only to tell you that the advances in artificial intelligence and virtual reality is becoming now in practical use. This is another way of virtual reality, okay? And the third thing after robotics and navigation is what we call 3D printers and patient-specific instrument. So we do patient-specific instrument using 3D printers. And how this work? We have this machine, which is a 3D printer. And as you can see here, this machine has been very, very expensive in the past, but the desktop machine on the right side is like 1,000 times less in the cost as compared to the big machines that has been there for a long time, and it has still being very expensive. So that 3D printers cost coming down, and the technology is becoming simpler, and this makes the interest in using 3D printers in medicine is becoming huge. And that's why I'm using this technology in my operations, almost in 95% of my operations. Let us see how can we use this 3D printing. First is 3D printing. We can use it to print models that can tell us if there is a tumor, for example, or a fracture. You can print the model, and the surgeon can look at the model, the patients can look at the model, and also they can plan the surgery. Okay, and I use it as a guide, which is again, this is the mainstay of my talk, what we call it patient-specific instrument that I use for knee replacement. So you remember the instrumentation that I showed you earlier with 300 pieces of an instrument. I can do knee replacement using these two guides rather than 300 pieces. And then the 3D printing also can help us doing plates and screws, which is specific for a particular case or patient. And also we can use even a custom-made implant or prosthesis. So it's a prosthesis which is done specifically for a patient. And eventually we can use this 3D printing to print spare parts for the human body, or what we call like a graft. So for example, if somebody has a tumor in the mandible, then you can have imaging of the other half, the normal half, and reverse it. And then with a 3D printing, you can print this from a specific material that's biocompatible and integratable with the bone. And this can replace that the other part which has a cancer or has any other problems. Okay, so let us come to knee osteoarthritis again and see how the problem, especially in Middle and Far East and in South America too, where patients leave the arthritis until it becomes really severe. And you can see here how the knee is deformed and how is damaged. And you can see the damage here on the bone and the complete loss of the cartilage and the deformity. So when you have two like this, I used to do only one knee and leave the other knee to do it later on after several months or several weeks. But usually patients are not happy, because when you straighten one knee, when you do the surgery, this knee will be straight and the leg will be straight, and the other one is still deformed and short, and patients are not happy. Therefore, I had to do bilateral knee replacement, which two knees at the same time. In order to do bilateral knee replacement, you need to use really a technology different from that conventional instrument that you have seen. You need to do with robotics and or navigation, but unfortunately, robotics and navigation takes long time, so we cannot do bilateral with robotics and navigation. In order to do bilateral knee replacement, they are standard criteria if you are using a conventional instrument. Unfortunately, this standard criteria does not fit, or most of our patients with knee arthritis who have bilateral knee, they don't fit into these criteria. They either their age is older, and when I'm talking about 70 years of age, that's for an active 70, not just 70 who's staying at home and not going outside and keeping indoors. Okay, absence of cardiac disease, controlled diabetes, body mass index less than 30 kilogram. The majority of our patients that I see are not fitting these criteria. This means that we should not do bilateral unless we have a new modality, a new technology that can help us doing bilateral, as I mentioned, like robotics or navigation. Here is a conventional instrument, as you can see. The previous picture that I showed and I skipped quickly is that's just showing an infection in both knees. That if you don't fit the criteria and you do knee replacement with the conventional instrumentation, then complications could happen. Two of the worst complication is infection, and the other second complication, which is even worse, is death, mortality. Patient could die because if you do two knees and then you go inside the medullary canal with this rod, because if you're using this conventional instrument, you have to use what we call it intramedullary guide. In order to insert this guide can kill the patient if you're doing a bilateral and not fitting the criteria for bilateral knee replacement. The reason for this is when you insert this medullary rod or guide, you can cause what called fat embolus. If you're doing a one knee, that's fine, the risk is quite low. But if you're doing a bilateral, then the risk is high. This is in addition also to bleeding, and this requires blood transfusion. Blood transfusion is not a big problem, but the big problem is really what's called fat embolus. This fat embolus is a killer. So if you do bilateral and you're not fitting the criteria, then you are at risk. So the technology that I'm presenting today is that rather than using all these instruments, I'm putting a cross here. I'm saying no for this conventional instrument. And I'm also saying no for violating this medullary canal with the rod that causes fat embolus by using what we call computer-assisted patient-specific instrument. Patient-specific instrument. So I am making an instrument specific for the patient in order to replace all these instruments and also replace the intramedullary rod. And in this case, I can do bilateral safely. So let us see how this works. First of all, I mean, infection control is essential. And when you're using conventional instrument and you're doing bilateral, keeping this instrument for a long time, then there is a high risk of really infection. As you can see here, this is the instrument. This is a lot. And the opposite is the top here. And this is the technology that I'm using, which is called patient specific. So these two guides with some supporting instrument, and I can do bilateral knee replacement easily. They are also, in addition to bilateral knee replacement, with this technology, there are certain conditions where the patients cannot have knee replacement without using a technology. Like all these conditions that is listed here. These are difficult cases where if you use conventional techniques, then there is a high risk of complications. And sometimes surgeons cannot do it. They do the knee replacement and they will decline doing a knee replacement because of the presence of any of these 6 problems. Okay. So what is my experience with bilateral simultaneous TKA? I worked, as I said, in UK, US, and Canada, and I have done no bilateral simultaneous TKA simply because bilateral simultaneous rarely exists, or the need for it rarely exists, because patients usually present early. They have one knee damaged, they have the surgery, and then when the other knee is damaged with osteoarthritis, then they can have the second surgery. But the situation here is different because patients present late, they present with 2 knees. So when I came to Egypt in 2006, I stayed for 2 years doing only very, very few cases with bilateral, because at that time I had either to use navigation or to use a conventional, but I have to follow the criteria for bilateral knee replacement. From 2009, and I've been using this new technology with a patient-specific instrument, the PSI, and this make a steady increase in bilateral. So my bilateral increased from 5% up to 95% now. So this is my current status now. 95% of the cases that I do are bilateral, simply because patients are coming and refer to me for bilateral knee replacement because I'm using this technology of patient specific. So what this technology is, simply we do a CT scan, and this is a step number 1. So CT scan of the knee, and then I have the knee in a software. So with the software, I have the prosthesis, I have a scan of the knee. And so this means that I have the patient on the computer and I have the prosthesis on the computer. This means that I can do the surgery. So with a clever software that can cause simulation of the whole surgery and make all the cuts and the preparation of the bone, and also select the proper size of the prosthesis, and also position the prosthesis accurately. And in this case, in addition to the CT scan, there is something called the scout view, which comes from the hip until the ankle. This is just like an X-ray. So it is not a scan. So it is not, there is no radiation in it. And with this, I can calculate the mechanical axis. So by having all these instrumentation, I will be able to do this surgery without using the medullary guides. Let us see how can we do this. The clever software will develop a template, a guide, or an instrument, one for the femur and one for the tibia. And this instrument is based on the surface matching of the bone. So it is used from or transferred from a virtual instrument into a physical instrument using the 3D printer. So that 3D printer will print these virtual models or template, and these templates can be sterilized and then used on the patients. It fit exactly because it is done specifically for this particular knee, and it does not fit for any other knee. Even for the same patient, you cannot put the right side on the left side. It has to be exactly the right template on the right knee. Okay, so once these templates are sterilized on the put in the patient, then the surgery can be done very quickly, easily, without using the intramedullary drill or the guide that you have seen earlier. Another big advantage is that we know the sizes beforehand. So rather than having a transsuit, very big one, having about 50 or 100 pieces or 150 boxes of different sizes of implant that goes with every operation, every knee replacement is done. Usually the distributor bring this bag with all the sizes, and the surgeon will select the proper size. So if you can imagine that the knee replacement is, the knee is opened, and the surgeon spend about 15 minutes or so to select the size for the femur and for the tibia, and to get the sizes from this box. This is the conventional technique. But on the opposite here, for the patient-specific instrument technique, we know the sizes beforehand. So we have only the 3 sizes for the implant, and some other 4 sizes just as a standby for only the plastic part, which is in the middle. So basically 1 femur, 1 tibia, 1 poly, and then another 4 poly. So total of a 5 poly insert, what they call it. So it's a very small number of pieces rather than having that large number of boxes. Okay, here when I do knee replacement, I just don't show the surgery because it's scary. But when I do bilateral, I do one side, and by the time the assistant is closing the wound, the other side is already like half of the operation is done. So this means that when I'm doing bilateral, you can say it is only half an hour more than when I'm doing one side or one knee. With this technology, I can do very complex cases like a patient like this who is a dwarf, this one only 126 centimeter, where conventional instrument does not fit. We can plan the surgery completely and do the surgery using this technology. Here is just a piece of the literature, just to be evidence-based and to show how this PSI technology has been proven as an evidence-based. Okay, and even the technology that I'm currently use is even better than that. Okay, I'm just going to skip these slides. This is just a comparison between the technologies that I am using and the similar technology, which is also called custom-made guides. Okay, and the differences, as you can see here, and the results are much better towards that patient-specific template that I use. As you can see from all figures, all these are published. You can look at Midline or Google under my name, Hafez, and you see all these publications. So basically, in summary, with regards to the criteria for bilateral simultaneous TKA, as you can see here, that the criteria for using conventional instrument are very strict, and it shows that very few patients can fit into this criteria. But when I'm using the technology of patient-specific instruments, then all these criteria are almost gone. I have done cases up to the age of 90 years that have comorbidities. Accepted means that hypertension, cardiac diseases, or diabetes, as long as the anesthetist can accept doing one knee, they usually accept doing the 2 knees if I'm using this technology, because the risks are very low. Most of these bilateral, they have what we call varus, valgus, or flexion deformities, which means that the leg is deformed. It's not straight, it's not normal. And body mass index also, I did for patients with a BMI, with a high BMI, with a body weight up to 130 kilogram, and above 130 kilogram, I usually do unilateral one side at a time. These again different studies which I have done, and I'm just going to I skip these slides, and I'm going to end my talk here, and I will be more than happy to take questions from your side.
First of all, thank you for your neat and clear presentation and explanation, Doctor. Folks, do you have any questions? You can ask the doctor one by one. Raise your hands and you can ask the doctor one by one. Yeah, Fahmida.
Hello, doctor. I'm Fahmida.
Hello, hi.
Hello,
Hello,
sir.
hi.
So that's really very informative presentation, doctor. And
Thank you so
I
much.
wanted to ask you, is there any particular food or medicine which we should avoid if we have knee arthritis?
Food or medicine? Um, Actually, no, because osteoarthritis, as I mentioned, is a degenerative disease. Okay, so it's either caused by the osteoarthritis or the arthritis in general is either caused by osteoarthritis or rheumatoid. If it is rheumatoid, it's something genetic, sort of. It's an autoimmune disease. If you have this disease, whether you eat certain foods or not, or certain medicine, I mean, it does not affect or make it worse. Okay. Um, the same for post-traumatic arthritis. Food or medicine does not make it better or worse. I mean, I mentioned about medications very briefly. There is health supplements like glucosamine, chondroitin sulfate, and other things which people commonly use in order to fight osteoarthritis. But there is no evidence scientifically for using these. There is no harm from using them, but the effect is marginal effect. And in my practice in UK, we don't prescribe glucosamine in hospitals, okay? And the same guidelines are also from US. And all these supplements are only having marginal effect, but they are not cost effective. This means that their effect is quite small, that is not equal to the cost of these medicines.
Oh, thank you so much, doctor.
Does anybody have any questions? Yeah, Boju Kumari.
Hello, doctor.
Hello, hi.
Hi, doctor. What are the potential risk and complications of osteoarthritis?
The complication of osteoarthritis or of surgery?
Complications, doctor.
Of arthritis?
Yeah, doctor.
Yeah, I wouldn't call it complications because complication is usually a term that it's used after treatment, whether medical treatment or surgical treatment, especially surgical treatment. Okay, but I will say sequelae, or I will say what is the natural history of knee osteoarthritis. If you leave the knee osteoarthritis, then as I mentioned, the cartilage will be completely worn out, and then the bone will be worn out, and then you get deformities. So as you've seen in some of the pictures, the patients will get even shorter because of this deformity. Their height will be less, and also you get bone loss, and then you get ligaments damage, and then the knee become unstable, and then patient will be prone to fall, okay, and cause more damage to their body. And their mobility will be decreased gradually, and then they became disabled. They will not be able to walk. So these are, the sequelae or consequences to leaving osteoarthritis without treatment.
Thank you, doctor.
Doctor, can I exercise if I have knee osteoarthritis?
Yes, if you have knee osteoarthritis, exercises is essential because exercises will help, first of all, the muscles to be stronger. When the muscles are stronger, it protects the joint. That's one thing. The other thing that the exercises for the joint, at least to keep the joint moving so that it does not become stiff. But these exercises has to be done with a medical advice or with a physiotherapist so that you make sure that you're not doing exercises that could be harmful.
Okay, thank you, doctor. Does anybody have any questions?
Yeah, doctor. So you mentioned the PSI technique that is invented by you, or are you the only one who's doing this technique as of now?
Yeah, the technology of patient-specific instrument, that's a good question. I started this technology in 2001, so very, very, very long time ago, okay? And I modified this several times. So what I'm using now is a technology. Um, um, it is my innovation, okay? I have 21 patents on this technology, okay? And these patents are taken by Surgeonovi, which is a UK company that's manufacture and do these guides for me. Um, when we compare this to what is available in the market or in Europe and US especially, there are other comparable technology, which is patient specific or custom made guides. You call it, they have many different names. You call it custom made guides, patient matched guides, or true match, you know, or PSI, many other different names. And their technology is not as good as mine. I could be biased, but I can tell you five main differences. First of all, in order to have this technology, for example, if you are in India and then you want using these custom-made guides from a company which is in US, it takes first of all about 6 weeks, but I do it in about 3 days. And it takes 6 weeks because all these different steps are outsourced and done by different companies. Okay, but my technology, we do something called hospital based, where we have everything in one place and we do everything so that it can be done very quickly. The second is that we use CT scan, they use MRI, and MRI is more expensive, and there are many patients cannot fit into MRI. And the third is that we do it for very complex cases, but there the other companies, they do it for only straightforward cases. And then you can question why you do it for straightforward, because I mean any average surgeon can do straightforward cases. We need it for complex cases like bilateral cases or complex cases. And the other thing is also the cost. It's much cheaper than the cost from other implant companies. So for all these differences that make the technology I'm using much better.
Um, Thanks, doctor. So if someone is taking your surgery, then how many hours it would take the entire surgery to be done?
Um, Good question. It depends on the speed of the surgeon. Okay. I am, for example, I'm not saying I'm a very fast surgeon, but there are surgeons who are by nature, they are faster than others. But I can tell you, if you compare it with conventional technique, it is either half the time or 3/4 of the time. Okay. So when you do bilateral, you really almost having like half of the time. So when I do bilateral knee replacement, is exactly like the time when I'm using unilateral with a conventional instrument, nearly like this.
Okay, thanks, doctor.
Which is, I mean, I can do bilateral for straightforward cases in less than 1.5 hours. Okay, for bilateral.
Does anyone have any other questions for doctor? Okay. I think no. Okay, thank you, doctor. We are really glad that you could take time out and conduct the much needed webinar on knee pain. So, and I also thank the participants for attending today's webinar. If you want to consult any doctors, you can contact Anavara. We are encourage you to connect with us on social media. If you have additional questions, you can contact us by email or telephone. We are happy to provide you additional support. Thank you. Thank you, everyone.
Thank you so much.
Thank you,
Bye-bye.
doctor. Bye.